Hello and welcome back to our channel Pharmalix, and today we are going to reinitiate our very famous GPAT Rapid Revision Series for 2026. And today we are going to discuss few important chapters of pharmacology. We are going to discuss the questions, and then we will also discuss how to solve this question efficiently and how to understand the basic pharmacology behind these drugs. And those who are visiting this channel for the very first time, please do not forget to subscribe the channel and also hit that bell icon so that all the updates regarding GPAT, NIPER and pharmacist vacancy should reach you at very right time. And also, if you want to learn more about the GPAT and NIPER and pharma vacancies, you can also join our WhatsApp group where we directly send all the updates on the pharma vacancies. So today we are going to discuss few chapters which is related to general pharmacology and autonomic nervous system, CNS pharmacology, cardiovascular system and some advanced level overall GPAT NIPER previous year questions. So without further ado, let's get right into it. So the first question is from general pharmacology and it says, which drug has zero order kinetics? So first there are few things which you need to memorize. Okay, so there are few things which you need to memorize that I will tell you later, and there are few things which you need to understand the concept behind the pharmacology. So which of drug has zero order kinetics at therapeutic doses? Okay, so zero order kinetics. What is zero order kinetics? So a drug which does not follows, or I should say a drug which is independent of the concentration for elimination. That means whatever the concentration is it low or high, the elimination will remain same. Okay, so is it the warfarin? No. Is it the enalapril? No. Is it phenytoin? Yes. And is it the propranolol? No. So phenytoin follows zero order reaction as well as mixed order reaction that I will tell you later. So let's understand why. So phenytoin is the correct answer. Phenytoin follows capacity limited metabolism. Once enzymes are saturated, elimination becomes constant, zero order kinetics. And you can also remember zero order drugs by PEP: phenytoin, ethanol and high doses paracetamol. These follows zero order reaction. And here in the diagram also you can see no matter what is the concentration, the elimination is constant. And in the first order, if the concentration will increase, the elimination will also increase. Okay, and here is the clear explanation for first order, zero order and mixed order. So first order, the definition says the rate of elimination is directly proportional to the drug concentration. More drug concentration in the body, more elimination per unit time. What does it mean? Let's get it by an example. If there are 100 mg drug present in the body, every hour it will become half. So 100 mg after 1 hour becomes 50, after 1 hour becomes 25, after 1 hour becomes 12.5. So after every hour it will become its half. So its T half will be 1 hour. Okay, so this is how we can understand that always 50% is removed because of the concentration. Now for the zero order kinetics, the rate of elimination is constant independent of concentration. Then whatever the concentration is, I don't care, the elimination will remain constant. Suppose if 10 mg is being removed from a 100 mg drug, so also let's understand by example. There is a 100 mg drug and every hour 10 mg will be removed, so it will give 90 mg, 80 mg and so on so forth. Okay, so every hour 10 mg will be removed, so the elimination becomes constant no matter the concentration. And here you can also have the half-life is not constant, risk of toxicity is high, and you can compare it with this, that here the half-life is constant and most of the drug follows first order kinetics. And we also mentioned that phenytoin is mixed order as well, because for the zero order, if it is at high doses, it will behave like zero order. And for the first order, it needs to have low doses. Okay, so this is how the mixed order reaction works. And you can also learn the examples from here. I have mentioned the examples let's get to our second question. So the second question says drug with highest volume of distribution, that which of these drug have highest volume of distribution. Is it heparin? No. Is it digoxin? Yes. Is it insulin? No. Is it gentamicin? No. So the correct answer becomes digoxin. Why? Because you can learn, this is a table from KDT, you can learn from it because every year one such question is asked from the table. So tables which are given in the KD Tripathi book or any pharmacology book which you are following, learn all the tables mentioned there. You will have to be careful about the tables. So here you can see warfarin is having low solubility tissue binding and volume of distribution also low. But when it comes to digoxin here, you can see the lipid solubility and tissue binding is high and it is higher in comparison to all these drugs. Okay. Alright, so let's move to our next question, which says drug causing mydriasis without cyclopegia. Okay, some technical terms. This question is from autonomic nervous system. So first let's understand what is mydriasis. So mydriasis is, in simple terms, mydriasis means dilation of pupil. Dilation of pupil. And then let's understand what is cyclopegia. So cyclopegia means when a person can't focus on near object because ciliary muscles are affected. Ciliary muscles are affected. So cyclopegia occurs due to ciliary muscle. So if the drug will work on ciliary muscle, cyclopegia will happen. So there is a drug which causes dilation of pupil without hindering ciliary muscles. So we have to find out which drug is it. Is it atropine? Yes. Is it tropicamide? No. Is it pilocarpine? No. Is it phenylephrine? So the correct answer is phenylephrine, not atropine. Why phenylephrine? This I will tell you the exact mechanism of action for phenylephrine, because phenylephrine has very specialized mechanism of action. First of all, the phenylephrine has alpha-1 receptor agonist. What is it? First thing, alpha-1 receptor agonist. Alpha-1 receptor agonist. And this directly act on radial muscle of iris. Radial muscle of iris. Okay. And this does not work on ciliary muscles. So ciliary muscles, basically ciliary muscles are controlled by, let me also tell you, ciliary muscles are controlled by M3 muscarinic receptors. And phenylephrine has no cholinergic action. So since it has no cholinergic action, it will not act on M3 receptor. Okay. So this is a lot to understand, but just process it, go through the video again and you will get to understand. Let's understand it. So the correct answer is phenylephrine. Explanation is phenylephrine is equal to, it is an alpha-1 agonist. It directly contracts the radial muscle. Pupils are dilated, but since it does not work on M3 receptor and it has no cholinergic action, it has no effect on ciliary muscles, and since there will be no cyclopegia. Okay. The trick is alpha-1, eye wide but vision is fine. Okay. If there will be cyclopegia, there will be blurred vision. Okay. And this is the mechanism of action of phenylephrine. That phenylephrine binds to alpha-1 receptor. GQ protein gets activated. GQ activates the PLC. PLC, phospholipase C, this makes IP3, inositol trial phosphate, and DAG, and IP3 increases the calcium, and wherever calcium will be there will be contraction. This I have always emphasized, that whenever there will be calcium, there will be concentration. Calcium increases the radial muscle contraction. Radial muscle pulls iris outwards and pupil dilates, and then there will be the condition called mydriasis. Okay. I hope you have understood the process, mechanism, and what kind of question can be asked from here. So there could be question related to mechanism of action. There could be questions related on the cyclopegia. There could be questions on alpha-1 agonist. So these kind of questions could be asked. So whenever you see alpha, M1, M3, H1, think of these mechanism. So there will be GQ, there will be IP3, there will be calcium, and then there will be contraction. Fourth question is drug of choice for organophosphate poisoning. Okay, this is a good question which we can understand. So let's understand what organophosphate does. So what organophosphate does is it increases the acetylcholine number in our body, the acetylcholine concentration basically in our body. So what it does, it inhibits the acetylcholine esterases. Acetylcholine esterases, if inhibited, it will increase the acetylcholine in our body. So any drug which inhibits the acetylcholine in our body will be the answer. So will it be atropine, neostigmine, physostigmine, or propranolol? So propranolol certainly not the answer. Physostigmine is also not the answer. Neostigmine also not the answer. So the correct answer is atropine, and atropine blocks the muscarinic receptor. So atropine blocks the muscarinic receptor, and since the excess acetylcholine will be reduced. So also you can also refer the sludge trick which I have also explained in our previous videos. So these are the list of important drug of choices for the poisoning, and you have to learn each and every one of them because these are very important, and every year at least one question are being asked. Next question is anti-epileptic acting by blocking T-type calcium channel. So an anti-epileptic drug that acts by blocking the T-type calcium type channel. So this is basically a mechanism of action का question. ठीक है? So a drug which has blocking activity of T-type calcium channel. So let's understand what is the mechanism of action of all these drugs. So what does phenytoin does? In simple words, if I want to tell you, the main action of phenytoin is to block the sodium. It blocks the sodium and causes tonic-clonic, and basically used in tonic-clonic seizures. For valproate, it blocks the sodium, let's say sodium plus calcium, and also increases the GABA. Also increases the GABAergic neurons. Okay, GABAergic activity basically. For ethosuximide, so this blocks the T-type calcium channel. T-type calcium channel. And for carbamazepine, it again blocks the sodium channel. Okay, it blocks the sodium. So the correct answer is our ethosuximide. So ethosuximide blocks the T-type calcium channel in thalamus. Drug of choice for absence seizures. Okay, so यहाँ से we can have two types of questions. First, the mechanism of action based question, and then the what kind of seizures. What kind of seizures it is used for. Seizures it is used for. Alright, so next question is explanation. I can also tell you how the other drugs are working here. So basically, if you can see here, the ethosuximide is blocking the T-type calcium channel. So the next question is long-term levodopa therapy causes. So levodopa therapy causes hypertension? No. Bradycardia? No. Hypoglycemia? No. Dyskinesia? Yes. So first thing, there are few things which you can also categorize by seeing the kind of questions. So levodopa, where have you heard or read about levodopa? Have you heard it in CVS, cardiovasculars? No. So these are all the hypertensive situation or drugs or situation related to cardiology. Whereas dyskinesia, the problem in movement, is involved with levodopa. So whenever you will read about the Alzheimer's and other such CNS related chapters, there you will find levodopa. So it is sometimes that kind of questions are also asked, and you can do them very simply. So the correct answer is dyskinesia. Chronic levodopa dopamine fluctuations, involuntary movement is caused by levodopa, and this involuntary movement is called dyskinesia. Next question. ACE inhibitors cause cough due to accumulation of. So basically, so here you will also have to understand what are ACE inhibitors and how does it causes cough. So whenever you give ACE inhibitors to someone for a very long time, they have tendency to develop the dry cough, and why, this we will discuss now. So ACE inhibitors, the simple trick is any drug which is having pril in the end. So enalapril, which we have just studied, enalapril, captopril. So these kind of drugs are ACE inhibitors. Causes cough due to accumulation of. What is accumulated so that it causes cough? Angiotensin 2, no. Aldosterones, no. Renin, no. Bradykinin, yes. So why? Let's just study it. So now let's understand how this bradykinin pharmacology works. So just understand, ACE always elevates bradykinin, and whenever there is high bradykinin, the mucus will be decreased and thus it causes dry cough. Simple, as simple as that. So here are some drugs along with their identified adverse effect, and this you'll have to learn, and there are few important which I want to mark and you have to go through them. So first is ACE inhibitors, which we have just studied, then ferrous supplements, benzodiazepines, warfarin aspirins, ACE again, digoxins, atorvastatins, and then we have prazosin, gabapentin, theophylline and ARBs, and then last one is amiodarone. So these are some important which you have to go through drug by drug. Next, drug contraindicated in asthma. So what are the drugs which are contraindicated in asthma, and why drugs are contraindicated in asthma? This is also we will understand. So first, before we solve this question, we will also have to understand the beta receptors. So there are three kinds of beta receptors: beta 1, beta 2 and beta 3. So basically beta 1 is present in two places, one heart and second in kidney, basically the JG cells of kidney. And when we talk about the beta 2 cells, it is basically present in the smooth muscles of bronchial, basically bronchial smooth muscle, I will write it like this, uterus, skeletal muscles, vasculatures, liver, pancreas and ciliary body. Just we have discussed about eye. And if we talk about beta 3, so this is basically present in our fat cells. This is present in our fat cells. So we also have a trick. So we have one heart. So beta 1 is present at heart. We have two lungs. So we have two part of lungs. So here I say two lungs. So beta 2 is present in the lungs. So beta 2. So in if any of the drug which is targeting, which is activating or which is stimulating beta 2 will be contraindicated in asthma. So there should be a non-selective beta 2 agonist, which will be contraindicated in asthma. So let's answer, will it be propranolol, will it be atenolol, or will it be metoprolol, or will it be nebivolol? So the correct answer is propranolol. Propranolol is a non-selective beta blocker, blocks beta 2 and causes bronchoconstriction, and that is why propranolol is contraindicated in asthma. And here are the classification which we have to learn, especially about the diuretics, RAS system, renin angiotensin system inhibitors, sympathetic inhibitors, and then we have ACE inhibitors, 81 direct renin inhibitors and alpha adrenergic blockers, as well as the central sympatholytics as well. Okay, so these are the few drugs which works here. So if we talk about the ACE inhibitors, enalapril, lisinopril, what they does is they basically decrease the angiotensin 2 and causes vasodilation and decrease the blood pressure. If we talk about the beta blockers, metoprolol, atenolol, what they does is they block the AT1 receptors, prevent the vasoconstriction and decreases the peripheral resistance. We talk about the diuretics, they decrease the calcium entry and causes vasodilation, and due to decreased blood volume, due to decrease in the water in our body, they also decrease the blood volume, and hence the blood pressure also decreases. Or if we talk about the central acting agents, clonidine, methyl dopa, which were used earlier, now it is very rarely used. So they decreases our heart rate and causes vasodilation due to the sympathetic tone. And then again the alpha blockers should be here, prazosin, doxorubicin, they block the alpha 1 receptor, causes vasodilation and decreases the peripheral resistance. So overall arterial blood pressure is reduced, cardiac output is managed. And here the calcium channel blockers. So calcium channel blockers, we have also read a trick which I have posted in my group. So if you want to learn about that, do join our WhatsApp group where I keep on posting about all the tricks and tips which we use in our GPAT and NIPER. So with this, let's move to our 9th questions. Which drug or drug causing grey baby syndrome? And before that, I also want to discuss the kind of drug we have mentioned in the options, such as chloramphenicol, gentamicin, ciprofloxacin and tetracycline. So these are the drug. So first of all, let's discuss one by one. So let's begin from the chloramphenicol. So chloramphenicol is the correct answer. It causes grey baby syndrome. And what about the gentamicin? Gentamicin causes ototoxicity. So see, we will follow the elimination method here. So gentamicin causes ototoxicity. If we talk about tetracycline, tetracycline causes tooth discoloration in babies. And if we talk about ciprofloxacin, ciprofloxacin causes tendon rupture. So this causes tendon rupture. And chloramphenicol, of course, the grey baby syndrome. And apart from that, this is only seen in neonates, and this is also due to the immature liver. Okay. And if we talk about the tetracycline, so after this, I think the most important would be tetracycline. I'll put a double star here. So this usually have the tooth discoloration and also bone growth inhibitions, and along with that, sometimes it also shows photosensitivity. Okay, that's how. So with that, the correct answer is chloramphenicol. Neonates lack glucuronil transferase, drug accumulates and thus causes cardiovascular collapse. So trick, chlora makes baby color disappear. This is also you can use, or you can make some of your own tricks as well. Last question for today is aminoglycosides causes hepatotoxicity, nephrotoxicity, hypotension or hyperglycemia. So previously also we have just read aminoglycosides. So aminoglycosides is an antibiotic, and we have also studied the trick in our previous videos, that buy at 30, sell at 50. So this AT means aminoglycosides and tetracyclines. They basically bind to the 30S part of ribosome and inhibit the bacteria. So basically they inhibit the bacterial growth process. So they are bacteriostatic in nature. And if we talk about what are the causes caused by aminoglycosides, so first of all, before we go on the causes, I wanted to discuss the common drugs which are in aminoglycosides. Basically, we have just read about gentamicins, amikacin. Amikacin you most of have maybe applied on your skin, used somewhere in rashes. Streptomycin, very famous. Tobramycin and neomycin. So what kind of questions are being asked from aminoglycoside? First thing, mechanism of action. Second, where it is applied, route of administration. It is applied in cream, tablets. What are the ADRs, which is in this question? What are the adverse drug reaction? And then lastly, they sometimes ask about the classification. Okay. So for aminoglycosides, basically the correct answer would be nephrotoxicity. So they are toxic to kidneys. So accumulation in the renal cortex causes tubular damage. So glyco, so we can understand, think kidney is a glycotubules. Okay, so they damage these glycotubules, such as tubular damage, and there we can understand the ADR related to these antibiotics called aminoglycosides. So with this, I would sum up this video. Thank you so much for joining. Stay connected and keep revising. For more updates, join our WhatsApp group where we keep on putting the vacancies, the tips and tricks for GPAT, NIPER and pharmacist exam. And for those who have joined this channel for the very first time, if you like the content, please hit the subscribe button, like our video, and hit that bell icon so that all the updates related to GPAT, NIPER and pharmacy should reach you at very right time. Thank you so much. Keep revising, keep learning.